Assalamu alaikum now. Now I would like to discuss about a very high-level topic that is prerenal AKI. It's a very easy topic, but while you are dealing with the question, for my case, I actually make lots of mistakes in diagnosing these prerenal AKI. Okay, prerenal AKI. AKI acute kidney injury can be divided into prerenal, intrinsic, and postrenal AKI. And prerenal AKI, it may be due to decreased renal perfusion. It may be due to decreased renal perfusion, like true volume depletion, decrease effective arterial blood volume, true volume depletion decrease effective arterial blood volume, heart failure, and cirrhosis, displacements of intravascular fluid like sepsis, pancreatitis, uh, and bilateral renal artery stenosis with AC inhibitor, and afferent arteriolar vasoconstriction like NSAIDs, afferent arteriolar vasoconstriction. We know that NSAID actually inhibit the COX cyclooxygenase, and cyclooxygenase actually is a vasodilates prostaglandin. So NSAID actually blocks these cyclooxygenase pathway in the afferent arteriole, and thus causing prerenal AKI. Okay. Um, Clinical feature: increase in serum creatinine 50% from baseline, decrease urine output, BUN creatinine ratio more than 20:1, FeNA less than 1. So BUN creatinine 20:1, FeNA less than 1%, FeNA less than 1%. And treatment is restoration of the renal perfusion. So in this uh, stem, if we do BUN by creatinine ratio, if you do BUN by creatine ratio, it is more than 20:1. It is more than 20:1, like uh, 46 divided by 2.2, so more than 20:1. So it is prerenal AKI. So why is this prerenal? Look here, the S3 is hard. So S3 is the signs of heart failure. S3 is the signs of failure. So S3 gallop or S3 is the signs of heart failure. So it is acute heart failure exacerbation. This patient has volume overload due to acute heart failure exacerbation, and the AKI is the most common cause, or most likely due to cardiorenal syndrome. Now I am reading this stem. A 54-year-old man comes to the emergency department due to progressing worsening shortness of the breath, extremity swelling, okay, decreased urine output, for the past week, medical history, heart failure with reduced ejection fraction, patient is on metoprolol or lisinopril, spironolactone, furosemide. The patient has been taking same doses of medication for the past 6 months and admitted me some doses now and then. Oxygen saturation 93%. Okay, show JVD distension. Show the JVD distension. So JVD distension is 3 bilateral hard in crackles hard in the bilateral. So these are heart failure. These are the features of the heart failure. There is abdomen is distended. So there is a signs of left heart failure causing the right heart failure. So it is cardiorenal syndrome. So elevated central venous pressure. It's elevated central venous pressure. These which of the following is the most likely cause of this patient acute kidney injury? It is due to elevated central venous pressure. This is cardiorenal syndrome. Cardiorenal syndrome. In cardiorenal syndrome, left and right ventricular failure, decreased cardiac output, decreased renal artery perfusion, decreased GFR, increased RAS, vasoconstriction, and sodium and water reabsorption, which will causing left ventricular and right ventricular failure. Left and right ventricular failure will cause increased central venous pressure and renal venous pressure. It will increase central venous and renal venous pressure, decrease glomerular filtration gradient, which will decrease the GFR. Okay. Okay, look at this question. The patient has UTI, got ciprofloxacin, then creatinine is getting higher. A month ago, her serum creatinine is 0.9. 2 weeks ago, he prescribed ciprofloxacin for UTI. Okay, previously serum creatinine was 0.9, now 2.1. BUN, if you do the BUN creatinine ratio, it is more than 20:1. So looks like AKI, and it is due to intravascular volume depletion. Okay, it is due to intravascular volume depletion. So it is prerenal AKI due to intravascular volume depletion. Mm, so hypovolemia leads to decreased renal blood flow and causes activation of the RAS system. Increased reabsorption of the salt and water occurs to increase the passive reabsorption of urea, resulting in increased BUN and creatinine. The term injury is somewhat inaccurate in the prerenal state, as the kidneys do not experience acute injury unless there is decreased renal perfusion and is prolonged, leading to acute tubular necrosis. Therefore, unremarkable urinalysis, absence of significant protein cells and cast is typical. Okay, so this is a very simple topic but very tough for me because I have I made wrong two questions. So while you are dealing the question, then it would be tough. So hope you enjoyed.